Okay, okay. Good evening, everyone. I would like at the beginning to welcome everyone in this meeting, the 12th webinar of Module 3 of the Comprehensive Neuroanatomy Educational Program, which is a live online series organized by the Yemeni Neurosurgical Society in collaboration with the WFNS and YNS Forum. Also, Pakistan Society of Neurosurgeons, Neurosurgical TV, and the Neurosurgical Couch. The trigeminal nerve, which is and with its pathways and vital clinical relevance, remains one of the most fascinating subjects in neuroanatomy. Today's session brings together experts and learners from diverse backgrounds to deepen our understanding, share insights, and foster discussion. I would like to introduce Dr. Sanallah from Pakistan, our moderator today. And really, I would like to extend my sincere gratitude to our speaker from Turkey, Dr. Aysu Kabakcı. Really, I would like to thank her for her presence, and she will today bring together either delegates and learners from diverse backgrounds to deepen our understanding, share insights, and foster discussion. Let us look forward to an engaging and with Dr. Aysu.
Thank you, Kabakcı.
Can I share my screen now?
Okay. You can share screen, Doctor.
Yes.
Dr. Aysu Kabakcı is a consultant neurosurgeon from Republic of Turkey, Minister of Health at Anarchy Turk City Hospital. She will give us today a presentation about the trigeminal nerve, surgical approach, and anatomy. Dr. Aysu, please, you can start.
So first, good evening, everyone. At first, I would like to extend my sincere gratitude to the Yemeni Neurosurgical Society and Neurosurgical TV for giving me this opportunity. So I am İyigün Kabakcı, as you said, and right now, actually, I am working as a research fellow at Almeida Skull-based lab at Indiana University in the United States, and still continuing as a consultant neurosurgeon in Turkey. And surgical approaches to the trigeminal nerve. I have no conflict of interest, so I will sequentially discuss the etymology, microsurgical anatomy of trigeminal nerve in terms of segments, nucleus, branches, and functions. And lately, I will talk about mainly focusing on the trigeminal neuralgia and how do we do the macrovascular decompression. So the name trigeminal nerve comes from Latin. So tri means tree and geminus means twin. So it conveys the idea of triplet referring to the nerve's three main branches. So it's also good to know that it's the largest among the cranial nerves. So 4 segments, which are the brainstem, sternal segment, Meckel's cave, cavernous segment, and the extracranial segment. So as we all know, the trigeminal nerve emerges from the lateral surface of the midpoints near the middle cerebellar peduncle to our nerve. So in the brainstem, it has 1 motor and 3 sensory nuclei. The motor nucleus is the motor nucleus. And we have mesencephalic principal sensory and spinal trigeminal tract and nucleus as the sensory nuclei of the trigeminal nerve. When we first look at the mesencephalic nucleus, it is just located in the lower midbrain and the upper pons, and it's just lies lateral to the sylvian aqueduct along the lateral margin of the periaqueductal gray matter, and it's anterolateral to the fourth ventricle. So it is responsible for conveying proprioceptive fibers from the extraocular muscles and the masticator muscles. So it modulates the force of the bite. And the second one will be the principal sensory nucleus, which convey impulses for tactile and pressure sense, and it's arranged in dorsoventral organization. And it lies just lateral to the entering trigeminal root fibers in the upper pons, and it has both cross and uncrossed fibers, which terminates in the ventral posteromedial nucleus of thalamus. And the motor nucleus is located just medial to the principal sensory nucleus, and fibers from this nucleus exit from the brainstem and medial to the entering sensory root, and it passes underneath the trigeminal ganglion without synapsing and become incorporated in the mandibular division, which is the only one who has motor functions among 3 branches. So the last one will be the spinal trigeminal nucleus, and it relates sensory modalities of pain and temperature, and it extends from the midpons until the cervical 2 to 3, and it lies just anterolateral to the 4th ventricle. And here we see the white matter dissection of the spinal trigeminal tract and trigeminal mesencephalic tract location. And after the brainstem, we have the cisternal segment. So these dissections are from my colleague, who is a great neurosurgeon from Turkey. I met him in Yeditepe Microneurosurgery Laboratory. And here I want to show, his name is Yunus Emre, by the way, and he's probably watching right now. And after emerging from the pons, here we see the cisternal segment of the trigeminal nerve, and it's located in the posterior fossa. So it passes below the tentorial edge, and then it enters the Mekias cave, which we see here. So this is the close-up view for the cisternal segment, and the nerve travels through the prepontine at first, and then cerebellopontine angle cisterns and the Mekias cave covering segment of the trigeminal nerve as a 3rd segment. So here we see the porus trigeminus, and then we see the Meckel cave. So Meckel's cave is where the trigeminal ganglion sits. So the trigeminal ganglion, the other names are the gasserian or semilunar ganglion, which is related with its shape. It contains most of the central cell bodies, and this ganglion is situated within the Meckel's cave, which is a CSF field space. So the trigeminal neurons within the ganglion are pseudounipolar neurons with 2 axonal branches. One extends just proximally to the brainstem, and the other distally toward one of the trigeminal divisions. Here is the close-up photo for porus trigeminus. And also endoscopic skull-based surgery, Meckel's cave is reached and visualized very well. And if we want to see Meckel's caves according to our target, we need to perform either transpterygoid or transmaxillary corridor. And this is again the endoscopic view. So Meckel's cave is spaced between the 2 layers of the middle fossa dura, which are the meningeal rail and the periosteal layer. And it extends from the posterior fossa into the posterior medial portion of the middle cranial fossa. So the contents of the Meckel's cave are the sensory and motor roots of trigeminal nerve and trigeminal ganglion and the arachnoid layer as well. So this is another view, 3D view from Yunus Emre's dissections. Again, here we see how emerge trigeminal nerve from the pons, and here we see the cisternal segment, and we see the Meckel's cave region with the trigeminal ganglion inside. And then it will give rise to 3 main branches. So the branches of the trigeminal nerve will be the ophthalmic, maxillary, and mandibular nerve. I will tell some about the branches as well, but I don't want to share a lot of details about because it's the trigeminal nerve has a complicated anatomical branches, a lot of branches. So I will try to summarize them. So the ophthalmic nerve is the smallest of three divisions. And as we all know that the oculomotor, trochlear, abducens, and the ophthalmic nerves lies within the cavernous sinus. So after emerging from the trigeminal ganglion, the ophthalmic segment is inclined upward as it passes forward in the lower part of the lateral wall of the cavernous sinus, and it reaches to the superior orbital fissure. So the ophthalmic nerve contains both sympathetic efferents to the pupillary dilators in ciliary body, iris, and lacrimal gland. And this also gives some efferents to the conjunctiva and cornea. And it also supplies the nasal cavity superior portion, the frontal sinus, the deeper structures like dura mater, and some anterior cranial fossa portions as well. So mainly the ophthalmic nerve will be responsible for the face and skull sensory information innervation superior to the palpebral fissure, eye, and the nasal cavity areas as well. So when we look for the branches of the ophthalmic nerve, we will have the frontal nerve, nasociliary nerve, and lacrimal nerve. Especially the lacrimal nerve will have some connections with the ciliary ganglion to have some parasympathetic and sympathetic function. So it has, as I said before, it has sensory and sympathetic nerve functions. And after it reaches superior orbital fissure, it gives that branches inside and after the superior orbital fissure. And we all know that superior orbital fissure connects the middle cranial fossa and the orbit. So the branches like nasociliary and lacrimal nerve goes through to the orbit. So it's the intermediate division of the trigeminal nerve, and it's purely sensory. It has only purely sensory function. So the maxillary nerve gives sensory innervation to all structures. So the maxillary nerve doesn't course in the lateral wall of the dural envelope of the cavernous sinus, unlike the ophthalmic nerve, and it courses beneath the dura of the middle fossa. Then it passes through the foramen rotundum, and it reaches to pterygopalatine fossa. So if you follow the trigeminal ganglion and you find the maxillary nerve, if you follow, you will end up with foramen rotundum, and then finally you will get the pterygopalatine fossa. So it has some connections with the pterygopalatine ganglion as well. Here we see the pterygopalatine ganglion located deep in the pterygopalatine fossa. So it gives rise some ganglionic branches, and they meet in the pterygopalatine ganglion. And then we will have the palatine nerves as well. So this ganglion gives rise to greater and lesser palatine nerves with its connections with the maxillary nerve. It has a lot of branches indeed. Median nerve is somehow, it's not exactly the branch of the maxillary nerve, but it somehow has some connection. So it has a lot of branches in the cranium, pterygopalatine fossa as well, and it gives some infraorbital branches to the infraorbital canal. And it has infraorbital nerve as the terminal branch of the maxillary nerve. And the second branch will be our mandibular branch. So it is the largest branch of the trigeminal nerve. And then this one is exiting the skull base through the foramen ovale, and it ends up in the infratemporal fossa. And it's the only branch containing both motor and sensory function. So motor root supplies mainly the mastication muscles, which are the masseter, temporalis, pterygoid muscles, and it also has some connections to the anterior digestive gully and the mylohyoid muscle. and it gets sensory information from lower facial third, mouth floor, jaw, and tongue as well. And this categorization according to the sensory function and the motor branches. And this is the endoscopic sublabial transmaxillary view summarizing the relations of the foramens, fossa, and the nerves. So if you follow the V2, the maxillary nerve, it goes it passes through the foramen rotundum to reach the pterygopolitan fossa, while the mandibular nerve passes through the foramen ovale to reach the infratemporal fossa. So to summarize the functions of the trigeminal nerve, it mainly has the sensory function, but small motor function and some sympathetic and parasympathetic function as well. So its sensory supply includes most of the face from mid-cranium to the lower chin, which includes the eye, external ear, and the general sensation of anterior 2/3 of the tongue. And its main function is the mastication. So it innervates temporalis, masseter, medial, and lateral pterygoid muscles. And then for other muscles, which are the anterior belly of the digastric, mylohyoid, tensor tympani, and tensor velo-palatine muscles. And as I said before, it has some sympathetic and parasympathetic functions. Parts of sympathetic functions is related, and the other all three has some parasympathetic functions, including innervation of the submandibular, sublingual, and parotid glands. So when we look at the exit zone of the trigeminal nerve, we see that it's the area is richly rich in terms of the vascular structure. So this natural organization entails certain consequences, which is mainly the trigeminal neuralgia. So here we see the superior cerebellar artery and its branches touching directly to the trigeminal root entry zone. So trigeminal neuralgia is traditionally called tic-tac pain disorder, and it's characterized by spontaneous and elicited paroxysms of electric shock-like or stabbing pain in the region of the face. And the poor quality of life can even lead to suicide. Comes from the name of the trigeminal neuralgia. So in 18th century, Nicolas Andre conceptualized the trigeminal neuralgia in terms of convulsive behavior, because he was believing that the grimaces of pain his patients expressed suggested that trigeminal neuralgia belonged to the same spectrum of diseases such as tetanus or spasms. So he coined this term to reflect both the pain that his patients describe as well as the facial spasms and the pain both together. So even though not all patients demonstrates facial spasm in conjunction with their pain, the name persisted as a tic douloureuse. So when we look up the etiology of the trigeminal neuralgia, we have classical, secondary, and idiopathic trigeminal neuralgias. So most commonly, we have the classical one with the percentage of from the neurovascular conflict of the trigeminal nerve. So we see mainly the arterial conflict, and it's mainly caused by the superior cerebellar artery. And less commonly, we can see the compression by anterior inferior cerebellar artery and the basilar artery as well. And sometimes we see venous conflicts, which resulted from the Dandy's vein, transverse pontine vein, and portal trigeminal vein as well. And sometimes in some cases, it might be a mixed conflict. And secondarily, we might have the cerebellopontine angle tumors, and important to remember multiple sclerosis as an etiology. And 10% of cases remains idiopathic. So here we see MRI scanning, but mainly we use the Fiesta. So here is thick arrow shows the trigeminal nerve here, and the other arrow shows the vascular conflict having a relationship with the trigeminal nerve entry zone. But sometimes, even after all the scanning process, we cannot see the vascular conflict, and it may not be visualized well. Therefore, the diagnosis may be based on the clinic of the patient. So this is the classical presentation of the patient with who suffers from the trigeminal neuralgia. So here we see one of the patients of Harvey Cushing suffering from an attack of trigeminal neuralgia. So this image is most likely one of the earliest photographs of a patient with this disease. So the neuralgia is characterized by paroxysmal attacks of unilateral, sharp, stabbing facial pain, and within one or more divisions of the trigeminal nerve, and it lasts sometimes less than 1 second, and sometimes it can be longer as 2 minutes, and it's usually precipitated by stimulation of certain trigger zones. So this is a study from Rome, and they collected the data of the 120 patients to show the main trigger zones of those patients. So the orange areas will be the most common trigger zones, and the purple ones are the less trigger zones for those patients. So when we talk about the approaches of the, it was initially treating with drugs, but they had a lot of medically refractory severe cases. So they started to perform the approaches. So firstly, they started with the demonstrating the without demonstrating the vascular conflict itself. So it's they make damage to the trigeminal nerve or trigeminal ganglion itself. So their target was the trigeminal ganglion at first, and then but then they started operating these patients, and it's an historical anecdote actually. And then he performed the first microvascular decompression without knowing it and not fully understanding the importance of these vascular lobes. And in the next series of his patients, he observed that compression or alteration of trigeminal nerve can be caused by an artery or veins. So that's how we started the microvascular decompression. So mainly we performed retrosigmoid approach for the trigeminal neuralgia. It's also called as the lateral suboccipital craniotomy, and it's the standard and most widely used microsurgical route for treating this trigeminal neuralgia. So the retrosigmoid approach provides a direct corridor to the cerebellopontine angle where the trigeminal root emerges from the pons. So it allows excellent visualization of neurovascular conflict and enables it preserves hearing and facial function when performed carefully and meticulously, of course. So now I'll show this step-by-step trigeminal neuralgia surgery which is the microvascular decompression, by step-by-step illustrations. So the operative corridors and trajectories for accessing the cerebellopontine angle we see here. So the superior part used for the trigeminal neuralgia, while the inferior part can be used for the glossopharyngeal neuralgia. So the and dural opening, inframedial cerebellar mobilization is done just below to the petrous and tentorial junction. And then we start to do careful arachnoid dissection, and we need to find the correct nerve as well. So as a tip, usually the 7th, 8th complex has a more superficial oblique inferior or superior trajectory comparing to the trigeminal nerve. And they shouldn't be mistaken to treat well. So after sharp arachnoid dissection, the trigeminal nerve root entry zone is exposed, and superiorly we expose the superior petrosal sinus. So it may be necessary to pay attention to the variations of the superior petrosal sinus as well. So this is another study from Richard Tubbs. So they classified 3 superior petrosal sinus elongation. So mostly it's located just superior to the trigeminal nerve root entry zone, but sometimes it can be just beneath this, and sometimes the superior petrosal sinus, as we see this in this image, it's sometimes it encircles the trigeminal nerve. So it's good to know the variations not to harm the superior petrosal sinus. And when we talk about the vascular loop causing the neuralgia, as we said before, the superior cerebellar artery, after emerging from the basilar artery, superior cerebellar artery has this this turn to the downward. So, and then sometimes its branches also can touch to the trigeminal nerve root entry zone here. And also, superior cerebellar artery is not the only case all the time. Sometimes it's on itself or its branches can make the compression. Sometimes it can be together with, we have trigeminal vein encircling the trigeminal nerve again. And then sometimes even the superior petrosal vein can have some compression to the trigeminal nerve. So after complete circumferential dissection, we will be capable of detaching the artery or vein, whichever compress the trigeminal nerve, and then after mobilizing the artery, the small pieces of Teflon are placed along the root entry zone and pushed ahead parallel to the nerve to prevent any vascular conflict along the root entry zone. And it's completed placing the Teflon all around the nerve and the vascular area. So this is the final view we get, and finally we can mobilize the artery along its entire length to be sure that it's gonna recur again. Sometimes fibrin glue may be used to reinforce this construct as well. And here it's another important point to say that sometimes excessive Teflon implantation might cause pain recurrence, causing the Teflon granuloma formation. So it's also another factor to pay attention. So mainly when we perform the retrosigmoid craniotomy or craniotomy, we will get this view. So it's important to note that the field and further away from the surgeon, whereas the 8 and 7 nerve complex is more superficial and follows an oblique inferior to superior trajectory. And this image shows the classical neurovascular conflict through a left retromuscular craniectomy. So here we see the artery compressing to the nerve, and this is after the reconstruction. And we have two decompression technique. Actually, we might the one I showed you before was the interposition technique. When we separate the artery or vein from the nerve, and then we put some Teflon technique as without using any Teflon here. And then also this can be performed either fully endoscopically and with endoscopic assistance, depending on the surgeon's experience. So it's the main steps are exactly the same. And then sometimes, in some cases, if we cannot dissect or if we cannot view all the circumferential trigeminal nerve, then we may need endoscopic assistance to see all angles around the nerve. So, and lastly, I want to show microvascular decompression surgery performed by my mentor, Abuzar Güngör. And this is from last week, actually. So here we see the neurovascular conflict, and this is the 3D view. Here we see the trigeminal nerve and compressing superior cerebellar artery, and here we have the petrosal vein here. And it's not, they didn't do the retrosigmoid craniotomy. It's a keyhole approach. It's like 1 centimeter in size. So this is the craniectomy in 1 centimeter in size. Here we see the dural opening. And then after arachnoid dissection, they release CSF to allow cerebellar retraction. I'm sorry. The first encountered nerve will be the 7th nerve, and they see the 9th cranial nerve. Here we see the 7th nerve again. And they're moving superiorly to see 5th nerve, the petrosal vein, and the superior cerebellar artery. And then he performs sharp arachnoid dissection around the nerve and superior cerebellar artery mainly. Now he is dissecting the superior cerebellar artery and trigeminal nerve. Again, sharp dissection continues. So it's important to dissect in a circumferential manner. Here we see the motor root of the trigeminal nerve. So after dissection, the Teflon is placed between the spiritocerebellar artery and the trigeminal nerve. And then also another Teflon placed between the petrosal vein and the trigeminal nerve as well, to be sure, to decrease the possibility of the pain recurrence. And this is the final view with Teflon embedded in the area. So this is the final view. This is the craniectomy. And here we see the trigeminal nerve without the loop conflict anymore. And this is the 3D construction of the scalp. So my references were the Eschergel book, Roton book, and the Neurosurgical Atlas. This is, I feel like my home, the Yeditepe University Neurosurgery Laboratory. The work mainly done there, over there. And then as Eschergel said, the more you see, the more you know, and the more you know, the more you see. To ensure the safety of the neurosurgical interventions, a comprehensive understanding of neuroanatomy is crucial. Thank you for listening.
Thank you, Dr. Aysu. I'm Dr. Sanola. I'm working as an assistant professor at Liaquat University. And I'm the moderator of this session. Sorry, I was a little bit late due to some technical fault. A very detailed and a very good lecture given by Dr. Aysu. And she covered all the aspects from anatomy to the all different surgical approaches, endoscopic assisted open MVDs. And I'm also thankful to the all participants who joined this session. So I request participants, they can contribute their experiences. They can ask any question regarding this lecture. Experience or want to ask some question?
Thank you, Dr. Aysu, for your great lecture. I appreciate your job. You show us very nice, explain everything. Thank you again. Just I'd like to ask two questions. The first one, what is the most complications of micro surgical decompression? And the second question, what are you doing with the patient who have got recurrence of pain or who did not improve after this surgery?
First, I mean, microvascular decompression sometimes as a complication, we can see the like ischemic stroke if we have the vascular damage. But I mean, I didn't see recently, but sometimes we might have the brainstem or cerebellar ischemic stroke due to the vascular damage, and sometimes also there is a possibility to get the hearing loss as well.
Yes.
And sometimes due to the incidentally damage to the trigeminal nerve itself can happen. But the other question was about the recurrence of the pain, right? So
Yes.
sometimes explorative surgeries can be performed if control image shows the conflicts is still going on. And also sometimes it can be caused by the Teflon granuloma. So the explorative surgery can be performed, but usually they suggest the percutaneous way to treat after recurrence of the pain. So this is another option.
Okay, thank you. Thank you very much. I started my practice with MVD and percutaneous procedures. I prefer the microvascular decompression for young patients until age of 60. After 60, I think the trigeminal neuralgia ablation by radiofrequency is the better for the elderly patients. This is my opinion. Recurrence from the ablation and radiofrequency ablation is more than MVD, so we prefer it for the elderly patients. This is my opinion, and just press or divert patients to do percutaneous procedures. But the MVD will be is the first choice for young patients. Anyone have any question? Please, you can.
Thank you so much for the lecture, Dr. Aysu. It was very interesting. I just have small question. I missed the point you said when you do microsurgical decompression. Do you use endoscopic assistance all the time or only when it's needed?
No. I mean, we don't use. I've never seen endoscopic assistance microvascular decompression. It was from the paper about the endoscopic microvascular decompression, and they say that if you perform microvascular decompression with microscope, sometimes you may use endoscopic assistance as well to see the 360 degree of the structures, like to be sure. It was like the suggestion of the paper. And they say that it depends on of course, the surgeons itself, himself or herself experience.
Yeah, because it's quite common practice to use endoscope as a assistance whenever you remove the tumor or whatever. So, okay, thank you.
Yeah.
So, are you using the neuronavigation in your procedures?
For microvascular decompression?
To get a small incision and to avoid injury and like this.
Yes, actually, for the last procedure, I wasn't there, but they used neuronavigation to decide the location of the keyhole.
Yes.
But it's like, how can I say? The neuronavigation was not showing well, actually. I mean, sometimes the knowledge of the to check all the time, but it's not like not always we use, I mean, some cases.
Okay. Anyone have any question, please? Do not hesitate.
Can I ask one question, Dr. Aysu? I hope my sound is clear because my internet connection is very slow today. I don't know why.
Yes.
In some cases of microvascular decompression, there is no obvious compression by arterial or venous compression on the nerve. And some surgeons say that you can do a nerve massage in that cases. What's your opinion about that?
I've never seen that kind of cases, but sometimes you do only the arachnoid dissection to relieve the nerve. But if after the operation, still the percutaneous options should be considered. If you cannot see the conflict itself, or after the operation, his or her symptoms doesn't resolve.
Thank you.
If you let me, I will talk about one story of my patients. I had one patient 5 years ago. he had hearing loss in one ear, and unfortunately we did not examine him, and he had trigeminal neuralgia in the other side. We don't know. It's our mistake that we did not test the hair in both ears. So after surgery, he become pain-free after our MVD, but unfortunately he lost his hair, his function in the same side. So he became he lost his hair totally, bilaterally. One from his history and one from our procedure. This is one of the painful history from my surgical interventions. That's why I became to prefer the percutaneous procedures for elderly patients. Sorry. Okay, anyone has any question? Thank you, Dr. Aysu, for your nice lecture again. Thank you, everyone who attend this lecture from near or far. Hope we can meet everyone again in next future. Thank you, Dr. Ahmed. You can finish this meeting.
Thank you, Dr. Abdulghani, and thank you, Dr. Aysu Kabakcı, for your participation with us, and thank you for all attendance, and also thank you for Dr. Sanallah for moderating this session. So see you all, inshallah, next week with more presentation, inshallah. See you all, inshallah, next week.